Hello, this is Dr. Paul Wang, Editor-in-Chief of Circulation, Arrhythmia, and Electrophysiology. I'm delighted to welcome you here today for our latest atrial fibrillation webinar. This is being organized by our atrial fibrillation advisory panel. Our advisory panels are under the direction of Daniel Morin, who's with us today. And I have the pleasure of introducing our moderators today, Professor Natalia Trayanova and Professor Peter Noseworthy. So take it over. Thank you.
Good evening, everybody. Thank you for joining us for this webinar. We are here today to discuss the March issue of the journal. The title of the paper is Machine Learning Derived Fractal Features of Shape and Texture of the Left Atrium and Pulmonary Veins from Cardiac Computed Tomography Scans are associated with risk of recurrence of atrial fibrillation post-ablation. Today we are joined here by the two joint senior authors on the paper. With us are Dr. Mina Chung, who is an EP faculty at the Cleveland Clinic and an expert on atrial fibrillation, and she will discuss the implications of the study. And Dr. Anant Madabhushi, who is a professor of biomedical engineering at Case Western Reserve University, with a number of appointments at medical school departments. We are joined today also by two discussants, Dr. Sanjiv Narayan, who's a professor of medicine and director of the atrial fibrillation program at Stanford University. Dr. Narayan has been a very prominent voice in the effort to use bioengineering and lately machine learning approaches in particular to personalize arrhythmia therapy and to improve the outcome of AF ablation procedures. We are also joined by Dr. Nassir Marrouche, who is a professor of medicine and director of the Electrophysiology division at Tulane University. Dr. Marrouche has pioneered the use of imaging and particularly of fibrosis assessment to inform AF ablation decision. Overall, both Dr. Narayan and Dr. Marrouche have been driving forces in digital health innovation.
Great, thank you very much, Natalia. So I'm very excited about this presentation today. I think we have a very interesting topic and a very provocative paper. We're all obtaining imaging before our ablation cases and in people with atrial fibrillation. And we tend to look at this with a relatively straightforward eye in terms of what's the size of the left atrium and so forth. But this paper really demonstrates that there's a whole world of information there that's hidden in plain sight, and that we can capture some of that information and bring it to the point of care to render some very important clinically relevant insights. So the way the webinar today is going to work is we will hear directly from the study authors, the co-senior authors, as you heard. They'll be giving us a presentation to introduce us to the study, the data, and the major things that have been learned along the way. And then we'll open it up to discussion from our two esteemed colleagues, Dr. Narayan and Marrouche, who will give us their interpretation of the study. And at the end, we'd like to field some of the questions from those of you who have joined us tonight. So what I'll ask you to do is go into the Q&A section and ask your question through text. We'll be keeping track of these. And then once we're through with the formal discussion, we'll bring some of these issues and discuss it as a group. So without any further ado, let me hand it over now to Dr. Mina Chung.
Thank you, Peter, and thank you, Natalia. And especially also thank you to Circulation, Arrhythmia, and Electrophysiology, not just for accepting our paper, but also for choosing it for this Journal Club webinar. So thank you, Paul and Christina, and also to our moderators, Dr. Natalia Trayanova and Peter Noseworthy, and our very distinguished panelists, Dr. Nassir, Marrouche, and Sanjiv Narayan, and also Dr. Dan Morin, who helped choose this article. As you heard, our topic tonight is predicting recurrence of AFib by machine learning on atrial CT scans. So if we go to the next slide, as you know, the cornerstone of AF ablation has been pulmonary vein isolation. But the success rate, as we know, is much lower in persistent atrial fibrillation. So the challenge has always been, how do we identify and can we better identify the targets for AFib ablation? Because even though we may be ablating even people with structurally normal hearts, there seems to be a ceiling of success. And even in structurally normal hearts, we may not get better than 80, 85, 90% success, and that may include redo ablation. So over the last few years, Dr. Anant Madabhushi and I and our group at Cleveland Clinic and Case Western Reserve University have been collaborating to try to identify so-called radiomic features of CT scans that might be predictive of AF recurrence after ablation. So if we go to the next slide, the first approach we took was led actually by now Dr. Michael LaBarbera, who is a medical student at Cleveland Clinic, Leonard College of Medicine, when we first started this off. And this involved extracting radiomic features to see whether or not they would predict post-ablation recurrence. So we identified 150 patients for a training data set and a 66 patient validation data set. These were patients who underwent first catheter ablation and had CT scans before ablation. Our endpoint was recurrent AFib within the first year after a 3-month blanking period. And this was pretty hard work. He extracted 40 features, including making many measurements, including size of pulmonary veins and angles between various pulmonary veins, and used 79 clinical features. Using this, with these, he looked at 16 combinations of 4 feature selection and 4 classifier algorithms to try to identify a reduced set of features and classifiers that best predicted outcome. And the best set had area under the receiver operator curve C statistics with the radiomic features of 0.68. And the clinical features had an AUC of 0.68, and combined it was 0.70. So it told us that we had a long way to go to try to make this better, but it was very valuable, and I think will be very valuable in what he's done in the past as we try to make sense of what we see with some of our other machine learning algorithms in the future. So on the next slide, the second approach that we took was led by Dr. Thomas Adefosu, and it was just accepted for publication in BMC Medical Imaging. I don't think this is even out yet, but what we did for this was to look at differential left atrial morphology between patients with AF recurrence and no AF recurrence by looking on by creating templates of patients who had recurrence versus who didn't. So in this set, which was relatively small but very useful, we had 68 patients, 31 who had recurrent AF and 37 who didn't. And we looked, created templates of 15 and 15 of patients who did and did not have recurrent atrial fibrillation, and then looked kind of pixel to pixel and in the regions to see what was different between patients who had recurrence and patients who did not. Here you see some of the results with red areas showing areas of difference. And we found some local shape differences around the pulmonary vein ostia and around the left atrial appendage. But also, things like at the roof of the pulmonary veins and perhaps along the posterior wall some. And then this brings us to our, this shows the results of that. As you can see here, we did a little better. And for clinical features in this data set, the AUC was 0.71. For the shape features, it was 0.67. And when we combined, it improved the performance to an AUC of 0.78. So there is some incremental value to the shape features. So this brings us to our article, which is approach 3, where we looked at machine learning derived fractal features in post-ablation recurrence. And if you go to the next slide, I can just show you the training cohort that we had. We had 137 patients who comprised the training cohort and 66 who were in the validation cohort. And you see their distribution here between AF and no AF, and also some of the patient characteristics. And I'll let, there's a mix of cryoablation and radiofrequency ablation in our training cohort. The validation cohort was actually an older cohort that was comprised of lone AFib patients. So, and at that time, they were all done with radiofrequency energy. So I'll let Dr. Madabhushi go over our approaches. Next.
Thank you, Mina. And just want to echo what Dr. Chung said. Just really want to thank KE for selecting this paper for presentation for the journal club discussion, and the moderators, the expert discussants, and really all the participants as well for joining us. And so Dr. Chung, I think, really very nicely set up the clinical problem, the clinical context. I might just add in a couple of things. And part of the reason for discussing some of the previous work that our group has done with Michael LaBarbera's work, which currently is under review, which was really interesting because it looked at this angular separation between the pulmonary veins. And so it was very laborious work with Michael, who I think is on the call, did a fantastic job in corralling all of these patients and really looking to understand what the angularity in the pulmonary veins, how that then was associated with risk of post-ablation recurrence of AFib. Now, Thomas's approach, which just came out in BMC Medical Imaging, took a slightly different tack where we wanted to try to understand at a macro scale where are potentially differences that might exist between patients who do have recurrence post-ablation versus those who did not. So in some ways, the previous approach that we just published was sort of an unsupervised approach where we were looking at one collection of patients who did have post-ablation recurrence and those who did not. And then by creating these statistical shape models for both the recurrence and non-recurrence cases, and then looking at a difference of these statistical shape models, it allowed us to potentially hone in on those areas that were different morphologically or in their shape or their distension between recurrence and non-recurrence. And that actually then led, like Dr. Chung mentioned, to areas around the left atrial appendage and related areas that really showed a differential distension, differential morphology between recurrent and non-recurrent cases. Now, the reason why I think that context is relevant here is because this particular approach by Dr. Marjan Feroznia, who unfortunately could not be on this call, was sort of the next step on this sort of the journey, if you will, on developing better radiomic approaches to really characterize subtle differences, morphometric, morphologic differences between patients who are at risk for AFib recurrence and those who are not. The previous approaches had taken a bit of a more macro level, shape-based difference kind of approach. But what we want to do here was to use fractal-based approaches that I'll describe in a second to really prize out more granular differences that might exist within the pulmonary veins, within the left atrial tissue, within the left atrium, to try to understand if there are more subtle differences in the shape and the morphology that our previous atlas-based approaches were not able to appreciate. And the goal was that if we could identify some of these more granular differences, then could these granular differences potentially provide more specific information with regard to who was at risk for AFib recurrence or not. And so just as you can appreciate from this, this overview of the methods slide, there were a whole series of different steps that were involved. So firstly, obviously, there was the data that was corralled. We had a training set where we had manual annotation done on a subset of cases to be able to train automated machine learning models for performing segmentation of the different compartments and the different structures in the heart that we wanted to interrogate. So essentially, we created an automated segmentation model using machine learning to identify the lumen, the pulmonary veins, and then it wasn't perfect. And once the segmentation had been done, it involved some degree of manual intervention, manual correction. But by essentially extracting the segmentations using this combination of automated and manual intervention, we were then able to apply the fractal-based approach to extract a series of features that related both to the shape but also to the textural appearance of these different compartments. And we used a combination of both two-dimensional fractals as well as three-dimensional fractal approaches. And then, while we used a discovery set of 137 training set patients to build our machine learning models coupled with these radiomic features that we were getting from the different compartments, those models were then tested on this holdout set of about 66 patients. I will just add a qualifier here that this wasn't a truly independent test set because they were also coming from the Cleveland Clinic, but we wanted to ensure that there was at least some separation between the discovery set that was used and having sort of an independent or relatively independent validation set. So let me perhaps provide a little bit of a intuitive background or context for these fractal-based approaches. So I think when we talk about fractals, we think about these repeating patterns, that of course have been made really famous by Mandelbrot and others. And of course, there's this whole connection of fractals and chaos theory and so on. But one of the interesting things about fractal analysis is that it's really had a significant impact in the image processing, computer vision, signal processing space. And the reason is because the fractal-based approach allows for capturing more subtle deviations or subtle perturbations in signals, be it a one-dimensional signal or a two-dimensional signal or even a three-dimensional signal such as a volumetric scan. And so what we used in this particular study was a combination of 1D, 2D, as well as three-dimensional fractal-based approaches to not only capture subtlety and variations in the shape of these different compartments, we were also able to use the fractal-based approach to try to capture differences in the heterogeneity and the textural patterns at a pixel level with the intensity on these CT scans for these different tissue compartments. One intuitive way of really thinking about this fractal analysis is drawing the analogy with Fourier space or frequency space. So if you recall the relationship between the temporal domain and the frequency domain, there's sort of, with the Fourier transform, there's a way of going for a signal can be transformed from the spatial representation, temporal representation, into a frequency representation. So if you think of it in those terms, then if you think of a structure like pulmonary veins or the left atrial appendage, if you think of something that's extremely complex and convoluted, then the corresponding frequency representation of a very complex shape is going to have a corresponding high frequency component in the frequency domain space or in the Fourier transform space. So by that same analogy, the fractal approach is really trying to capture essentially more complicated, more twisted, more granular structures by really trying to capture this sort of increased frequency component in a sense. And that's really what this fractal dimension is doing, because the higher the fractal dimension, the greater the complexity of the corresponding structure that's being resolved by using the fractal operator. And so there's sort of a bit of a laundry list here of the various kinds of features that we extracted. And what you can also notice here is that there were features being extracted from the different compartments, from the left atrium, from the left atrial wall, as well as the pulmonary veins. So a series of different features. And like I mentioned, one of the things that we want to do is not just look at the subtlety, the complexity in terms of the shape, but also try at the same time to capture variations of the texture. So the nice thing about the fractal-based approach is that not only can we look at subtlety and shape, we could also look at the subtlety of the textural patterns with respect to the pixel intensities from these various different compartments. One of the things that we did was to really look through this entire laundry list of features that we were extracting from the various different compartments and really establish on the discovery set as to which of these features were truly discriminating between patients who were at risk for atrial fib, for recurrence of AFib versus those that were not. And so by looking at this in a univariate way, we were able to identify which specific subset of features within this larger set truly were able to distinguish between those patients at risk of recurrence versus those that were not, and only those that were really deemed to be significant based off the test of significance and the p-values, only those were then moved forward for consideration for inclusion into a machine learning model. I think it's also relevant here to say that one of the things that we were really interested in doing with this particular approach was to take a more interpretable machine learning model-based approach to the problem. There's a lot of interest right now on deep learning and neural networks, and we resisted that because we wanted to make sure that as we built our models, there was an ability to connect the features back to the specific attributes that we were looking at. In this case, like I said, texture as well as shape of these different compartments. So ultimately, we landed up with a set of 5 top fractal features that really distinguish between patients who did have AFib recurrence versus those who did not on the discovery set. And, you can see that it was a combination primarily dominated by shape-based features, but there was one texture-based approach that was also included. One of the other things we also did was trying to understand what was the relevance or the importance of the individual features, and also what was the relative importance of the features with respect to the compartments that they were coming from. So we used an idea called variable importance projection, which allowed us to really map the 5 features that we got back to the individual compartments. And so we were able to identify which of these features were most important. So you can see here that the shape-based features from the left atrium turned out to be among the most important feature from within this list of 5 features. The texture also turned out to be important. The features of the pulmonary veins turned out to be fairly important as well. So this was, again, just going back to this concept of providing interpretability and intuitiveness with respect to the features. I think was really critical as we organically built this model. We also wanted to look at how not just the fractal features alone, but what was the connection, what was the association with the clinical features. So we also did an analysis with respect to the type of AFib. We looked at sort of a multivariable analysis, looking at the association with age, the catheter technique, hypertension, and other factors. One of the interesting things that came out based on the qualitative assessment of the fractal-based approach, like I said earlier on, if you think of the fractal dimension, the higher the fractal dimension, the more the complexity of the shape that is being picked up. And so what was interesting was that we found that patients who tended to have recurrence of AFib tend to be characterized with a higher fractal dimension, in turn reflecting a higher anatomic complexity of the pulmonary veins, the left atrial appendage, and the left atrium. On the other hand, patients who did not have recurrence post-ablation tended to have a lower fractal dimension, suggesting that there was a lower level of anatomic complexity and surface variation. We also looked at the textural-based features, and again, similar to the shape story, we found that textural heterogeneity seemed to be more pronounced in patients who tended to have AFib recurrence versus patients who did not have AFib recurrence. So not only was there higher complexity in terms of shape, there was also more complexity in terms of the textural appearance of these different compartments. So when we looked at the various different models, we constructed a few different models. There was a model where we looked at the clinical parameters alone, a model where we looked at the radiomic parameters, all the best possible radiomic parameters, and then finally a model that actually combined both the clinical as well as the fractal dimension features. And so the clinical features came in at about 0.70 in terms of the area under the curve. The radiomic features by themselves came in at a 0.81 AUC. And what was really satisfying to see was the fact that when we combined the clinical parameters with the fractal dimension, we were able to get up to an AUC of 0.87 on this independent validation set of 66 patients. And so to conclude, I think what the study revealed was that fractal analysis of the morphology of the left atrium and the pulmonary veins from CT scans were predictive of AFib recurrence after catheter ablation. The type of AFib, paroxysmal versus persistent, was correlated with the 3D texture features of the left atrial myocardial tissue. But beyond the AFib type, fractal analysis provided significantly improved prediction performance over the clinical features, suggesting these fractal dimensions are capturing structural content and predictive value that goes beyond what might be explainable based of the clinical features alone, or even beyond what might be explainable based on the left atrial volume or AF and AF persistence. So with that, I will end and just do a quick shout out to the team, both at the Cleveland Clinic as well as Case Western, who helped us put this study together. Thank you very much.
Thank you very much, Anant, for presenting the paper and the technical aspects. It was very interesting to see how you guys developed the model. We're going to have a discussion now with our panelists. So I am going to give the floor to Dr. Sanjiv Narayan to give us his view on your study as a discussant, and then we'll follow up with Dr. Nassir Marrouche.
Thank you very much. Anant and Mina, fantastic paper. I'd like to congratulate you on it. Really exciting and intriguing findings. And I think you gave a really lovely overview. And Natalia and Peter, thanks a lot for inviting me to discuss this paper. Let's see if I can just share my screen. If not, we can do without, but it should be possible. Terrific. Okay, what have I got here? So I just put a couple of slides together just for the audience. It might be useful to give some context. So Anant mentioned the role of fractals as a mathematical construct of self-similarity. The notion really is that you have a geometric structure that can be described mathematically, which is similar at multiple scales. And so this has been shown in many aspects of nature. You can see it in crustaceans, you can see it in geography. And these are great examples. These are a Norwegian fjord on the left. You can pull these off Google, obviously. And on the right, the UK, soft spot for that one. And this is a famous example because as you sort of zoom in further and further and further on the UK coastline, same in any coastline, in fact, then the degree of self-similarity and geometric complexity actually can be represented and is often the same. And so that's one aspect of fractal scaling. I'm sure Anant could give me a lot more details, but that's my interpretation of it. And so it's a way of looking at how far you can go in dimensions and still keep a level of self-similarity in scaling. It's a very nice way of describing it. Now, the approach has been used in a few studies in the past. In fact, this is an interesting one in autism. In fact, Donna, and actually this is from another Noseworthy, and this was in PLOS 1 in 2017, looking at fractal dimensional scaling in the cerebral cortex, giving a trigger for autopsy. But of course, for autism. But you would, of course, expect that these are functional areas of the brain. So perhaps you would see some degree of complexity in different conditions. I think the idea of applying it to the heart structure for AFib is phenomenal. I was really intrigued by it. Particularly the idea that, of course, if you look at the figure that Dr. Faruznia, Mina, and Anant portrayed in their central illustration, you obviously have branching structures in the PVs. And of course, you could almost imagine that as you started to scale and look at higher and higher resolution, you could see small pulmonary venules at greater and greater scales, which poses the question, does the physiology that far away from the ostia matter. And does that matter because it's indicating fibrosis more distally? I'll leave that one for Nassir. Does it indicate because, in fact, some of the triggers are originating there because of early autodepolarizations, for instance? Does it matter because they're stretched and so the cells actually are calcium loaded, again, causing triggers, et cetera, et cetera? I thought it was terrific. And I'd like to get a little more clarity from the authors just to, so I understand the technique better of what the hedgehog plots show. It would be great if they could describe that for us, but I'll just quickly move on. There were obviously a few things about the study, and Mina did describe them. There's a slight imbalance between the validation set and the test set. So, sorry, the training set and the test set. And the basic idea is you train some sort of supervised learning on a training set. You say, this is an input that I know is AF success, learn it. And then you say, this is an input which is AF failure, learn it. And then you do it again and again, multiple times, often thousands or tens of thousands of iterations. And then when it's done, the model can input any new training, any new test set and tell you, predict AF success or failure. So if you look at this, as Mina said, actually, there was a slight difference between the type of ablation and the type of, I think perhaps the proportion of paroxysmal persistent that maybe they could discuss. That would be interesting. I think it's the fact that it was still predictive is remarkable, and maybe it means that these features are independent of the type of AF, and maybe they're independent of the type of ablation that was done, which is quite possible. I just wanted to get their thoughts on that. And then just wrapping up, there's a lot of interest in this area. I'll leave Nassir to talk about MRI. Of course, he's the pioneer there, but just generally the notion that you could look at the structure and predict function, I think is amazing. Now, Natalia's group has done some great work in this. Julie Shade had a lovely paper just a few months ago where they looked at MRI. They took high resolution maps and identified regions consistent with fibrosis. They then added to that by doing computational modeling and showed that the whole structure, both the structure or the function or the model, each were predictive, and the best was coming when you put everything together. And that actually was able to predict PV success in a pretty homogeneous cohort. This is another paper, that was MRI. So this is another CT paper by Xian Chen's group, where they didn't discuss exactly how they got to the result, but very briefly, they were able to predict PV triggers or non-PV triggers in a retrospective cohort. And so when I finish off, I really loved this paper, and I was honored to be asked to discuss it with you guys. To my take, and it's intriguing that distal branching of the PV is important. Is that what you're saying, or are you just saying that some complexity, including that, is important? Second of all, the question that always comes up with imaging is, what's the resolution? And how many voxels do you think you get across the LA? And how many voxels do you think you get across each of the distal, more distal portions of the PVs as you get into the PV venules? Motion artifact is something that probably isn't so relevant, but you could imagine that if the cases were done in AF, then the shimmer of the atrium during a CT that's captured could increase the frequency of the complexity during the image. I don't know if that's relevant, especially since you'll only get a few voxels anyway. They'll probably just be consistent, but it's a thought. Did any patient have prior ablation? Forgive me if I missed that from the paper or supplemental. And then again, what are your thoughts on taking this down to the most simple reductionist approach? What are the most simple metrics that would matter? And here's an oldie but goodie from Peter, 2005, looking at the impact of respiration on PV diameters. Could that sort of thing matter? And I'll stop there and just again congratulate you on a very novel and really clever study.
Thanks so much. Before you stop sharing your screen, maybe you could just leave that up. And before we go on to Dr. Marrouche's discussion, we could hand it back at this stage to the authors, Dr. Madabhushi and Dr. Chung, to maybe make a few comments on each of these points, and in addition, some of the other issues that you raised and questions you raised.
Sure, maybe I could take a first stab, and then perhaps Mina could chime in on some of the other comments that were made. But I think perhaps you could just go to the hedgehog plots that
Yeah.
talk about, which thank you for, thank you for bringing that up. That's a really great question. So this is essentially a way of trying to capture this fractal dimension. I talked about sort of this 1D fractal dimension, where you could think of sort of, so maybe let me step back for a second. So one could apply fractal analysis to ECG data. So you could look at just sort of temporal data, you could look at time signal analysis and take the fractal dimension and try to understand just in terms of sort of an ECG or EEG signal, what is the complexity? So you're looking at one-dimensional data and you could come up with a fractal dimension that essentially reflects the complexity and self-repeating pattern, Sanjiv, like you so eloquently put it, of this one-dimensional signal. You can take it and apply it in 2D as well to an image and essentially get a two-dimensional representation of the fractal dimension. And so what we were trying to do here was, because we were looking also at the three-dimensional version of the fractal dimension for these different compartments, what you're actually seeing here is how this fractal dimension plays out in 3D. So essentially for so if you think of it spatially, you think about the left atrium, you think of the pulmonary vein and the different compartments. So spatially, there is a fractal dimension that is associated with different regions of these geographically of these different compartments, and that's actually getting mapped out in 3D. So essentially, every one of the locations on the pulmonary vein of the left atrium is defined now by an X, Y, Z that reflects the fractal dimension in the three different axes. And that's sort of what is getting mapped out here. And essentially what the hedgehog plot, the shape or the flatness is also an indication of where the most complexity is. So is it in the Y-axis, is it in the Z-axis? You can see here, for instance, with B, the B plot for the left atrium, when you look at the AF positive versus the AF negative, it's actually giving you an indication that essentially there's one particular axis where there's significantly more variation in the fractal dimension versus in those patients that do not have recurrence. So that's sort of indicative. It tells you sort of which of these axes is more of that variation really being captured and really being critical. So I just want to sort of clarify that. Thank you so much for bringing that up. I think that was a great question there. I'll maybe just mention a couple of things, and then perhaps Mina could take a stab at some of the other questions. I will
put Anant, for the sake of fairness, we will need to give the floor at some point to Nassir and to the audience. So we would appreciate touching on these points, but faster. Thank you.
Okay, so I'll just say I was just going to say that series of different things that we'll need to consider in the future. We haven't looked at motion artifacts is one thing. We definitely want to look at different scans from different scanners, different slice thicknesses, number of different issues that we need to interrogate going forward. Yeah, maybe Mina can chime in as well.
Yeah, I just these were first ablations, but we certainly want to look at change as well from prior ablation, and the differences in the two populations is very interesting. They were different temporally too, but the fact that actually we had validation, statistics that actually were so good, actually. That's actually more remarkable, that we could validate it in a different population. I don't know.
Agreed.
Yeah.
Terrific. Should I stop sharing my screen?
Yes, thank you. Thank you, Sanjiv. We would like to hear Nassir's thoughts on the paper. Thank you.
Has my screen stopped sharing?
No.
Excuse me. Let me try.
Thank you. It's done.
Thanks. Perfect.
Before I start, full disclosures, I was Mina's fellow. I'm not sure anybody knows that. I look older than her now, but I was her fellow. She trained me in EP. Mina, Anant, great work. And that Mina Chung is working on machine learning. It tells you where we are today. She was our driving basic scientist in inflammation in Cleveland Clinic, and now she's driving machine learning work. Beautiful work. I can only echo what Sanjiv said. Congratulations, brilliant work, great start for a long journey. I can see everybody who's, I can tell you about my team and probably everybody else started looking at these data very, very carefully, especially what we get excited about is the integration of fractal features or the methods to apply them to machine learning. There's a lot of excitement in our group. As you know, we are biased. We love to see images predicting something in arrhythmia management. And I want to turn this immediately into my questions and details. I think Sanjiv was brilliant in summarizing your approach and everything else and giving to the audience what we use this for. From my perspective, I really like to focus more on 2 points in this paper, which is very important. Number one, CT scan, as you know, compared to MRI, is such a available modality. I mean, for the last 14 years, if you tell me what's the most annoying feature of every research we did, it wasn't anything else but the availability of the MRI scan in centers and clinics and so on. I was very intrigued by the fact, and seems everybody been flying about this very quickly, the fact of texture, that you defined some texture, and you flew over this very quickly, which is for me is the highlight of your paper. You use CT scan to define texture, and by the way, this is texture. We've been trying to define, as you know, as an electrophysiologist, and I speak on behalf of everybody on this screen. Texture, you can't say texture to an electrophysiologist without spending some time on it. Probably Mina told you that too, is what I'm dealing with, what's a texture? And when you differentiate textures within that atrium, I like to know that. I love that image you showed with different textures, but just an image with a predictive model, not location specific, not color specific, that can orient me more into understanding the next step of using this modality, obviously, and applying it into my practice. And I want to try to understand as well, and this is a question to Mina, and the pulmonary veins itself, it seems from the model, looking at it carefully, and this is very helpful in terms of seeing that the pulmonary vein model was the most powerful predictive in terms of, outcome. And this is this something, I know you corrected for cryo versus PVI versus RF, but did you look at as we all know, how far we are from the ostium, very close to the ostium, all these features from your cartoon maps that you did, Mina, did Anant get the chance to integrate this into the model? I think, obviously, if you have the lesion formation at 3 months would be even more powerful. And by the way, I encourage you to start tapping into the decaf patients that Osama have and using as we speak, because you have a lot of lesion formation data at Cleveland that Anant can tap into and integrate this into the structure, which I would love to see this applied into this model, right? So you have all, as I know from Osama, you have around 70 patients, at least more than what I'm seeing here, just from the decaf and the other studies we're doing with you. So these two, I love the idea of, again, the fractal integration. This is talking to everybody, and I don't know much about it. I get to learn about it recently with spending time with Shan Ho and his team at Triad, that they gave a lecture actually to us, so that means, and I think Sanjiv summarized to everybody, this is beautiful work. Recurrence of AFib, obviously you're looking as we speak, and I imagine this is the next thing I'm excited to know, is more important than the recurrence of AFib. How can we apply this to outcome data? At Cleveland, as I know you have tons of outcome data in terms of mortality, in terms of stroke. I want to see more of those, I think, and that's a beautiful image. And I missed in your model, Anand, and maybe you can tell me why, is the appendage. I see a lumen. And as you know, we started to consider the appendage as an independent chamber in EP when we go into the heart every morning, trying to do ablations and others. It became a different entity. And the work that we've been doing with Alan Morris and the team is to look at, is how the shape, we published on this couple of times, the shape predictive models, which seem to be agreeing with the MRI data on this. But we looked at this, so appendage seems to be playing an important role in these patients, and then not only predicting, but guiding us, and in terms of predicting hard endpoints in our patients. So these are the 2 points I wanted to make from this beautiful work, and there's a reason why Paul decided to highlight this into this webinar. It's beautiful, 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 beautiful. You open a new concept for everybody to start looking at and building on, and encouraging people to do so. And we need more people like you, Anant, in our teams to help us move this field to the next level. And thank you, Natalia and Peter, for allowing me to be here, by the way.
You're very welcome, Nassir, and thank you. Mina, Anant, would you want to address some of Nassir's questions?
Thank you, Nassir, for your comments. And obviously, we would love to be able to apply it to MRI as well. And we actually have a small AHA grant to do that. So we should talk about being able to collaborate together with for the MRIs. It's another order of magnitude, it seems, since you have like the time dimension to MRI. So it's a lot more complex. But I think that would be very, very interesting. Your point about the left atrial appendage, we still need to analyze left atrial appendage. So we have not focused on the left atrial appendage at the time that we did this. We hadn't, and that is clearly something that we can do off our CT scans and pay more attention to the left atrial appendage. So I look forward to collaborating and being able, obviously the more data sets that you can bring in and collaborate with, the better on these kinds of studies. So it'd be great to be able to open through this venue more collaboration, so we can advance this even further and perhaps personalize it in the future.
Great.
Yeah.
More comments?
So maybe I think Nassir had a question about the texture that maybe I'll just take a quick stab at. So Nassir, you're absolutely right. I mean, texture clearly played a role, and texture has been around for over, I'm going to say, about 50 years. If you go back to the early 70s with the famous paper by Harlech looking at two-dimensional co-occurrence statistical texture features, looking at joint statistics, really that work has demonstrated now that texture appearance, looking at variations in pixel level intensities within small neighborhoods, clearly has an implication in diagnosis, prognosis, even prediction of therapeutic response across so many indications. In this particular approach, I apologize for sort of just blowing through the textual piece. One of the interesting things about the textual analysis here was that, again, it was driven by the fractal-based approach. But I think it's worth qualifying here that there are multiple ways to define texture. There's no one specific way of capturing texture. We decided to go with fractals for capturing this heterogeneity in the pixel level intensities. But I think it's just worth noting that there are other approaches, and one of the directions for future work with this particular study is to actually look at some of these other ways of capturing texture to complement the fractal-based approach. So that's something we certainly will look to explore going forward.
And this is a way to, if you can add it, that's important because you have experimental models at your medical school, which is beautiful labs I've seen recently, and you should take these hearts and scan them and histologically correlate them. But this is the first next step we should do, and will be all of us waiting anxiously to know what you find and how you can define. Like we did originally with the fibrosis, we went back from the MRI of the experimental heart and went backwards. So I would do the same thing at one of the Osama's or Mina's experiment, and take that heart or take that in experimental model and scan them. and define. That's beautiful, because you see this scan, it seems to me it's easier reproducible and faster than
I'll just mention, actually, it's a great point that you made. It's interesting. We actually were just awarded a few months ago an R01 with Ken Margelis at the University of Pennsylvania, where we're looking at machine learning of the pathology images. So we're looking at endomyocardial biopsies and essentially applying ways of capturing the texture, the heterogeneity with the H&E images coming from these hearts, from these endomyocardial biopsies. So actually, it's interesting you should mention that, because with that project, there is a way of now really bringing these two streams of data, looking at what's happening at the radiographic scale with what's happening at the pathologic scale. So it's a great suggestion.
Thank you all very much. I'm going to give the floor to Peter. We have only 10 minutes to go through the questions that the audience have. So Peter is going to lead us through those.
Great, yeah, thank you very much. So the audience has raised a number of questions, and I'll go through each of those now. Julie Shade asked about the clinical implications. So I'm curious as well, what are we going to do with these results? Will this help us tailor our ablation approach? Will it select patients maybe who we wouldn't ablate at all? How do you see this playing out, and how do we make this clinically useful as possible? Maybe that should go to Mina.
Well, we hope that we're looking forward to taking this forward. You know, at this point, we're not clinically using it, but we hope in the future we will. We have submitted some of our work and our plans as an R01 and got what we hope is a fundable score. And the whole intention of that is to really be able to target regionally, identify regional targets that may be useful in ablation. So we're hoping that is where this goes.
And I understand it's a combination of manual and automated processes along the segmentation and then so forth. So how available would this be at the point of care and in real time in the day or so before an ablation, and how much more work would be needed to do to take action on this kind of thing?
Well, I mean, I'll happily admit that, I think we've got a way to go with the automated segmentation. I think that, this is one of the challenges with training the automated segmentations, particularly machine learning basis. You've got to provide annotated data, and we've struggled a little bit there. And in fact, back to Nassir's question about the left atrial appendage, I think one of the challenges we had there was just the automated segmentation. Truth be told, it was just the complexity of training the machine learning model to capture that. Was one of the reasons we didn't end up actually looking at that. So I think we've got some work there. I think that's one of the things, if this grant happens to come about, then one of the things that we definitely want to do is to make sure to shore up the automated segmentation to improve the throughput and the efficiency of this process.
Great. A technical question came up about whether all of the images were obtained on the same scanning protocols and the same type of machinery. We've seen examples in the literature where these kinds of models are very sensitive to the method of acquisition. So can you speak to that, and how consistent and generalizable would this be to machines across the country?
Yeah, so I got a two-part answer to that. So one is, I think that there was some degree of variance because these were patients with a scan, and I think Mina alluded to this, is that there was sort of an older cohort of patients and a newer cohort of patients. And so because they weren't sort of from a continuous set, there was variance there with the imaging. Having said that, we didn't actually explicitly do very much to try to address for variations explicitly. The second part of my response, though, is that is an active area of investigation within our group. In fact, we put out papers on chest CTs, not cardiac CTs, but chest CTs, where we've done more careful studies looking at how these radiomic features vary across slice thickness, reconstruction kernels, just kilovoltage and so on. And one of the critical pieces, I think, that one needs to consider is that constructing not just accurate models, but also stable and generalizable models, because I think this is a really, really critical issue with machine learning in general, that it seems to work okay when you're looking at data from a very qualified set of circumstances or qualified set of parameters. The moment you step outside that, your models start to break down very quickly. So that's something that we're paying a lot of attention to.
Okay. we're seeing a lot of applications of machine learning to medicine that have the issue with it that it's essentially black box type interpretation. And you've really turned that on its head and taken a different approach where you're essentially extracting features which in theory should have some pathophysiologic relevance and understandability, and then integrating those in a way that leverages some rudimentary ML approaches. But maybe you could talk a little bit about the balance of completely unlabeled data and a pure convolutional neural network, for instance, versus feature extraction and then integration.
Yeah, I think that there's potentially an opportunity to do some discovery there. I mean, I will say that from some of the work that we're doing in other domains, the way the most exciting thing I like about neural networks and these convolution-based approaches is the opportunity to hone in on, particularly with these visual attention maps, where the network can give you a sense of where it's spending its time, where it's paying attention. But then once you identify that, then maybe those become the sites where you do a deeper radiomic focused interrogation and look at more interpretable features. And so I think that's sort of, I envision a hybrid approach where you could use the neural network unsupervised strategy to first sort of identify targets for computation interrogation, but then having identified those targets, take the more interpretable approach to those regions.
Mm-hmm. Do you think a neural network can see the fractal dimension without it being fed that explicitly, or?
It's possible, but I mean, I will freely admit that I'm a big skeptic there. I think we hear a lot about the interpretability and that the neural network is really capturing the fractal dimension and so on. I've just got my doubts there. I think there's a lot of really exciting work, theoretical work that's happening on trying to provide more interpretability to CNNs. But we're not really quite there yet. I think at the best right now, we've got these visual attention maps, and I think that they have their utility. And so that's the way I see some of these hybrid models emerging in the short to medium term.
Great. With just about 3 minutes left, I'll hand it over
Peter,
now.
there are a couple questions on the Q&A. Like if you go up, there is one, I'll read it.
Go for it, yeah.
Yeah. One of the attendees is interested in knowing whether procedural characteristics could be additional features on top of radiomic and clinical features. This is a question more for Mina.
Yeah, for sure. I mean, the cryo versus RF was one example of that. And it would definitely make a lot of sense to include those.
But also, since you're predicting pre-procedurally what happens post-procedure, would it make sense to include, let's say, whether you did just PVI or you did also the posterior wall, right?
Yes.
Then the outcome would be quite different. These groups are separate in my mind in terms of outcome, potentially.
Yeah. You're right. I mean, that's exactly, we actually are capturing that in our next iterations, and we'll be incorporating some of that.
And so do we have we have 2 minutes. I'll read one more question. For all EPs, how often do you use the pre-op CT images to plan guide AFib ablation beyond ruling out LAA thrombosis?
I don't know if you want us to answer. I have a because we want to look at these CTs.
You're on the spot, so
CTs or MRs, on just about everybody. But I realize that may not be the case for everyone.
Okay, let's see.
We use them. Yeah, we use CTs routinely. We're moving more and more to MRI because of certain members of the panel.
Yeah, let's see whether we have anything else. I don't know whether, Mina, you guys can speak for 1 minute regarding Nassir's question about the distance from PVI to PV ostium. That's a question here.
PVI, you mean the actual ablation from PV ostium? Yeah, we have not looked at that.
I think the carto maps, Mina, maybe.
The carto maps, yes. So on this, we have not integrated, obviously, the electroanatomic.
I'm sorry, I'm saying carto maps. There's Abbott maps. There is
Right.
I don't want to be biased here on the call.
Speaking of, yeah,
Like the
speaking of
call.
different systems and trying to integrate between them, that'll be a whole different order of magnitude. But yes, we are collaborating actually with Ben Shoemaker at Vanderbilt, and he has a nice collection of electroanatomic mapping of the pulmonary veins. So, hopefully we'll be able to incorporate that, and hopefully we'll do better as well on collecting the electroanatomic maps to include in this.
I think we will have to wrap up our discussion. I really appreciate you all presenting today, and we were all very enthusiastic hearing about your findings. It was an excellent seminar and a lot of interest from our audience. Thank you all very much for coming, for attending this virtually. And there is a seminar, I believe next week, because we delayed this by a week. So please stay tuned, check Twitter for all the series that are coming out of CircuitP. Thank you all very much, and have a nice evening if you're not going straight to bed.
Thank you very much.
Sorry.
Thank
Thank you. Take care.
Thank you.
Thank you all.
Bye.